Our final session, session 6. I have a complete monopoly on the moderation for this session. My co-moderator was not able to be here today, so I really have a lot of control for the next hour and a half or so here. And this final session is on the implementation of host genomics in clinical care of infectious diseases. And we are going to kick it off with a local speaker, Magda, to my left, who'll be talking about data to diagnosis, the clinical implementation of genomic insights, stories from the NIAID program.
Good morning, everyone. My name is Magdalena Walkiewicz. I am a board-certified clinical molecular geneticist, and it's a pleasure to be here today and tell you about our experience with the centralized sequencing program at the National Institute of Allergy and Infectious Diseases here at the NIH. I have nothing to disclose, and just a brief overview. I'll begin by telling you a little bit about our program, then I'll move on to molecular diagnostics, and then I'll try to tie all the aspects of molecular diagnostics that I'll discuss into this case example to illustrate some of the points that have been made throughout this meeting. Before I begin, I really would like to acknowledge the commitment of Dr. Stephen Holland here to the clinical molecular diagnostics at our institute, and then also Morgan Similik, who is a genetic counselor and a co-lead of the program, for her work prior to the inception of our program that really lifted the effort that I will be discussing here today. So the centralized sequencing program is a team of board-certified clinical molecular geneticists, genetic counselors. We have some postbaccalaureate fellows that are supporting us as well, and technical staff. And our mission is pretty simple. We offer everyone who enters the clinical center for a study at our institute a molecular workup that currently includes genome sequencing. We interrogate that data for primary diagnoses, meaning the reason why they are seen at the clinical center, secondary findings, which are the 80+ genes recommended by the American College of Medical Genetics to be looked at when genetic testing is performed. These results are then summarized into a report that is uploaded to our medical record. The results of these studies are communicated with both the referring team as well as the patients. And then we hope that these diagnoses allow us to provide better treatment, prevention, and prognosis. In addition to this paradigm on the top, we host the genomic data in one spot, and we hope that this allows us to perform reanalysis of the data as new disease genes arrive, but also we leverage the data for new gene disease discoveries. We are interested in understanding how polygenic risk modifies some of those phenotypes that we look at. And last but not least, we look at contribution of structural and mosaic variants to disease. And then on the other hand of this model, and the pointer is not working, are some of the studies that Morgan discussed yesterday in her talk, meaning how our patients are understanding the results that we discussed with them, and we hope that these studies then can help us perform our job better and communicate these results more effectively. There is a little bit of an overview of our history. We started in 2017, and initially, we offered exome and chromosomal microarray. We then introduced a rapid turnaround time for clinically sensitive cases. In 2020, we switched from exome to genome, and then as several algorithms for interrogating the data became available, we implemented them as well. Those allow us to look at repeat disorders as well as copy number variants. We did a pilot study in 2023, and we currently have a couple of pilot studies utilizing long-read genome sequencing for our participants. On the bottom, what I'm showing you is the history of the services offered through different institutes around the clinical center, and then on the y-axis of the numbers is the accrual, or how many patients are currently on the protocol. So let's talk about molecular diagnoses. I just wanted to mention that our exome and chromosomal microarray data has been published, and those were the two PMIDs on 2 slides before, so I'll just focus on the recent work performed by one of our molecular geneticists, Bryce Seifert, where he looked at 1,300 individuals that were referred for genome sequencing recently. And then this allows us to, our studies allowed us to establish molecular diagnoses for a little bit short of quarter of our participants. These included primary diagnoses, secondary diagnoses, dual primary and secondary diagnoses. We've reported a few incidental findings. And then if you look at the bottom of that graph on the left, we have some variants of uncertain significance that we deemed high priority, and this just goes back to the conversation with Ivan yesterday. We just don't have enough evidence to push them to likely pathogenic, but we are highly suspicious that these variants are disease-causing. And then also the risk alleles are something that was discussed yesterday as well. These are the alleles that predispose to disseminated cocci, colitis, and so forth, which are not necessarily Mendelian diseases, but they do confer susceptibility to the disorders that we are interested in looking at. So why are these molecular diagnoses so important? They really can inform treatment, and that includes therapeutics, consideration for transplant, and this includes both either hematopoietic stem cell transplant or thymic transplant. And then the growing field of gene therapy, both gene addition and gene editing. I just wanted to spend a second on this slide. On the top, I'm just showing the first the second part of the last century, where there are several pharmaceuticals or treatments that were described, but I just want to focus on that bottom 3 panels and those medications described here. And I just wanted to say that the last 20 or so years, where we really are able to understand the molecular pathways that govern pathogenesis of the diseases that we study, have been instrumental in either discovering new medications or actually borrowing medications from other specialties, including oncology, and including these medications or therapeutics for our patients, where they are really much more effective and have much fewer side effects. So understanding these molecular defects that drive the diseases really can inform personalized treatment for our patients. I don't want to really talk about this too much because Dr. Pak is the leader in hematopoietic stem cell in children with primary immunodeficiencies, but again, just want to pinpoint the fact that genetic diagnosis does improve the outcome of transplants, and you can appreciate the number, 93% overall survival rate in individuals where we know what the molecular defect is, versus 58% in patients that we do not know what the lesion is that drives the disease. And last but not least, consideration for gene therapy. Over the last 30 years, gene addition has really been, in a way, leading the field with the development of new vectors that are much more that result in much fewer side effects. That field has really exploded, and there are several successful clinical trials that have been carried out. Several are pending, and there's a lot of preclinical work for targeting different genes. And same situation with gene editing. There are clinical trials pending for some of the genes already. Some of those clinical trials actually happening at the clinical center, and then a lot of work in the preclinical space. So now switching gears to pharmacogenomics and polygenic risk. So the genomic data that we use for providing molecular diagnoses can also be used for looking into pharmacogenomics and polygenic risk scores. And this is a study and research interest of Morgan's with help from Laura Amendola. And when Morgan looked at a cohort of over 3,000 patients for whom we performed genome sequencing, 87% of these individuals had at least one at-risk diplotype. When she then cross-referenced those patients with the medication that was in our medical record that was prescribed for these patients, 1 in 3 of these individuals had a medication and a pharmacogenomic finding that could alter the medication that's prescribed. And obviously, when you look at the meds that we've listed here, these are some of the frequent flyers in our institute, which include medications for treating infections, but also a lot of supportive drugs, SSRIs, opioids, and such. Therefore, from the conversation earlier today, I don't think doing these panels for patients outside of the clinical center really necessarily means like how often are we going to treat someone for an antifungal, but they have such a cross utilization for other medications that are much more frequently prescribed. Some of the data that we are also interested in interrogating in is the common variation. As discussed yesterday quite a bit as well, we often talk about the variable expressivity or non-penetrance of some of the disorders that we deal with. There is absolutely, there is quite a bit of evidence that common variants in the form of polygenic risk scores modify the phenotypes that we look at, and some effort that we just basically started at the beginning of 2024 was to utilize the data that we already have and look how those polygenic risk scores, or if they associate with some of the phenotypes that we often see in our diseases. And this is work completed actually by our ERDA under the supervision of Dr. Yan, and we were able to show that, for example, when we look at patients that have asthma and compare these patients with controls without asthma, that although the effects are small, but you can clearly see a shift, and the polygenic risk scores are higher for individuals that have the phenotype, and that's also true for inflammatory bowel diseases. We started to look at this just this year. There are a lot of other phenotypes that we are interested in, including inflammation, autoimmunity. We are also interested in looking at lung disease and whether there are some common variants that predispose patients to bronchiectasis and so forth. So ongoing work utilizing the existing data that we currently have for our patients. And then I'm just going to talk about this case example to kind of illustrate the points that I've been making throughout this presentation. So this was a 3-year-old female that was referred to us for a history of eczema, abscesses, fracture, and recurrent infections. And she actually came to us with a diagnosis of STAT3 hyper IgE recurrent infection syndrome. But because we are interested in not just the main molecular diagnosis, but also the other aspects that I've discussed here today, we performed genome sequencing for her. and her parents. And in addition to the primary diagnosis that we've confirmed in her, we also identified a pathogenic variant in LDLR, which is one of the genes on the secondary finding list. And that particular variant in that individual was inherited from a mom who had a history of hypercholesterolemia. For this particular individual, we also had the pharmacogenomic data, and it transpired from that data that this individual was a rapid metabolizer for this, but as conferred by the STAR1, STAR17 allele in the CYP2C19 gene, and she also had a allele that resulted in decreased function of the SLC01B1 gene. As far as the first, STAR1, STAR17 diplotype, this has direct impact on either dosing or avoiding voriconazole therapy for her infections. And when I actually reviewed her medical record, there was a note in our system that she was treated with voriconazole and could not tolerate that therapy at all. So it actually all made sense once we put all those pieces together. And then obviously for the treatment of high cholesterol, statin therapies are very frequently used, and once again, her genotype predisposes her to statin-induced myopathy, and probably that medication is counterindicated, or maybe the dosing needs to be altered for her. So I think this particular case perfectly illustrates the power of a genomic approach to diagnosis, where we are not just looking at primary findings, we are also implementing secondary findings, and then pharmacogenomics that can guide some of the treatments that we can propose for our patients. With this, I'm just going to leave you with some summary thoughts. I think, this is not really the crowd that I need to convince that genomics plays a crucial role in both primary and secondary diagnoses, but also pharmacogenomics can be informative in how we treat our patients. I think, the field of polygenic risk score, I know that there are a lot of laboratories in the outside world that offer some of those, but I think that is still a very unexplored area, and I hope that in the next few years we'll be able to make some leeway in how to think about these data and how to incorporate them into medicine. I didn't really have a time to talk about mosaic variants, but we have a huge effort on our team looking into mosaic variants from the existing exome data and seeing if we can identify new disease gene associations, or even look at existing genes and see if there are some mosaic variants that drive the disease in some of our patients. And then last but not least, I think I am personally, and I think a lot of people on my team, super excited about the possibility of changing from short-read long genome sequencing to long-read genome sequencing, as this new technology allows us not only to face variants, for some of our older patients where parents are not available, or they don't have children that want to participate, or just no way to face some of these changes, but also to really start to understand some of these difficult to sequence through regions because of either self-chains or pseudogenes and so forth. And in our field, IKBKG, NCF1, and Haydn, which we often see in our patients with primary ciliary dyskinesia, are of a challenge because we really just cannot really understand what the molecular architecture of these particular regions looks like. And last but not least, I think the last American Society of Human Genetic meeting was just eye-opening to me about how much better structural variant calling is from the long-read data, and it also helps to resolve some of these really repetitive regions, not necessarily trinucleotide repeat disorders, but regions that are pretty repetitive in nature. So I really think we are in an exciting area of genomics. I am just super grateful that I get to work in such a great environment where we don't have to worry about insurance coverage. With that, I just do want to acknowledge my centralized sequencing core team. I actually don't work because we have so much fun on our team that it's just really a pleasure to be in the office or do our studies. And then the support that we received from the clinical center all around. We work with 2 bioinformatic teams that support our efforts on both managing the data as well as incorporating all the new evolving technologies, algorithms, and so forth. We have a support from the Department of Laboratory Medicine where we do some of our confirmations and so forth. And HGRI has been crucial in helping us with some of the difficult secondary findings. This is really the work, the collaboration with Les Biesecker and Jennifer Johnston. And then just our institute and all the other institutes that chose to collaborate with us on genomics. It's just been such a great pleasure.
Thank you. That's really an amazing program y'all have built. Our next talk is from Katherine Calvo, also from the NIH, who'll be talking about germline versus somatic variants and other considerations in clinical next-generation sequencing.
Good morning, everybody. So I'm the chief of the laboratory, the hematology laboratory service in the Department of Lab Medicine in the NIH Clinical Center, and I am a hematopathologist. So looking at predisposition to hematologic disease, and this also is relevant for other disease types, there are many different types of mutations. We are typically looking at somatic or acquired mutations that arise in specific cells, drive the development of cancer or benign disease associated with the tissue of origin. And there are germline or constitutional mutations that are typically inherited, present in all cells, and may be present in multiple family members. And then there's another subtype of de novo germline mutations that are not detected in the parents, but are germline in the patient, and these may have arisen in a germ cell, such as a sperm or an egg. Given the exponential growth of NGS in clinical practice, there's increasing recognition that germline predisposition to bone marrow failure and hematologic disease is much more common than we previously thought. There's also increasing detection of germline variants on NGS panels that are designed for somatic mutations, particularly in pediatric and young adults with MDS and AML. So there are common types of clinical genetic testing. Most of you are probably familiar with this already, but single gene sequencing or Sanger sequencing. This is fast and can be used for confirmation of NGS findings. However, it has low sensitivity for somatic variants or germline variants where there may be somatic genetic rescue. And then NGS targeted sequencing panels. These are very common in the cancer world. Genes on the panels may vary depending on what we're looking for. In my lab, we have myeloid, lymphoid, hematologic malignancy genes, also immunodeficiency genes, and genes associated with inherited predisposition. The regions of the genes sequenced may vary on different panels. Some panels are more focused on hotspots. Some have exons of genes, and some have whole genes. Somatic panels, again, can detect germline variants if the gene in the region is on the panel. The advantages are that the testing is rapid. It can be 72 hours to 3 weeks, largely depending on whether the lab batches samples. The depth of coverage can be very deep, up to 5,000 or more. Many genes are sequenced, it's high throughput, and a small amount of DNA or RNA is sufficient. Now there are a lot of panels where we can sequence both DNA and RNA at in the same assay. Disadvantages are technical limitations due to either the panel or pipeline dependent. Often large deletions, translocations, or copy number variations can be missed. And then important regions of genes may not be included, such as intronic or regulatory regions that are critical. And then obviously there's whole exome sequencing. a large portion of the genome is covered, but non-coding regions can be missed, and the depth of coverage is low and often too low to detect somatic mutations or germline mutations with SGR. Longer turnaround time, this can be problematic in the transplant setting. And similar for whole genome sequencing, the turnaround time is longer, obviously, but the advantage is that you're pretty much covering the whole genome. There are also important tests to remember: cytogenetics, FISH, SNP array, CGH, and now optical genome mapping in the clinical lab is emerging. One important thing to note is that the clinical analysis pipelines are much more stringent than research pipelines and much less flexible. So what we've seen in the hematology lab is an overlap in the phenotype of genetic diseases that present in hematology, immunology, infectious disease, and rheumatology clinics. And some examples: unrecognized GATA2 deficiency has presented in hematology clinics as aplastic anemia, or MDS. Unrecognized ADA2 deficiency has presented as Diamond-Blackfan anemia in hematology clinics. Unrecognized CTLA-4 deficiency often has presented as aplastic anemia. And then unrecognized VEXAS syndrome can present to hematology clinics to rule out MDS. So our approach in our clinical molecular hematology lab is obviously to have a panel that is designed to detect somatic variants associated with hematologic malignancy or clonal hematopoiesis, and then also to include genes that predispose to hematologic malignancies, again, so that we can capture patients who may have constitutional variants. Obviously, these have to be followed up with bona fide germline testing. And additionally, now we're adding genes that are related to immunodeficiency, autoinflammatory disease, or immune dysregulation disorders that may present with cytopenia. We also have a panel approach that we want to incorporate new genes over time as new discoveries emerge. Talking a little bit about specimens, peripheral blood and bone marrow cells are relatively easy to obtain and contain constitutional variants, although the VAF may be impacted by somatic genetic reversion. They also contain somatic variants associated with clonal hematopoiesis or neoplasia. In contrast, cultured skin fibroblasts are really the gold standard for detecting germline constitutional variants. There's no contamination with hematopoietic cells that may harbor clonal hematopoiesis or germline mutations that may be affected by SGR. A number of labs also analyze hair follicles or nail clippings or buccal swabs to detect germline mutations. However, there can be some degree of contamination from monocytes or other hematopoietic cells in these specimens. The common rules of thumb regarding interpretation whether something can be somatic or germline typically historically have been: if the VAF is about 50%, it may be a heterozygous mutation. If it's close to 100%, it may be homozygous, and that somatic variants are typically less than 30%. However, this approach can be very misleading. There are a number of somatic variants that can have VAFs close to 50%, and germline variants can have VAFs under 30% in the bone marrow and peripheral blood if somatic genetic rescue events occur. And here's some examples. RAS-associated autoimmune leukoproliferative disorder is a disease that has features that overlaps with ALPS. When this was first discovered, it was originally reported as harboring constitutional NRAS mutations, as the variant allele frequencies were about 50%. Later, when hair follicles were sequenced and were found negative for the RAS mutations, it was realized that this is actually a somatic disease. And recently, the newly described VEXAS syndrome due to somatic mutations in UBA1. This is a severe autoinflammatory disorder in men. The UBA1 variants are often at very high VAF of about 50%. So originally, when this disease was discovered, it was considered that it may be due to constitutional variants. However, when the peripheral blood was sequenced and compared to fibroblasts, here you can see in this diagram that peripheral blood had very high VAFs. However, the fibroblasts were negative for the mutations, confirming that this is actually a somatic disease. So somatic mutations can be drivers of benign disease and have variant allele frequencies of less than 30%. If we're not considering the possibility of somatic mutations driving disease, we may miss them. If we think about somatic mosaicism, in general, again, germline mutations, if we look at peripheral blood, bone marrow, fibroblasts, and sperm, we're expecting a variant allele frequency of about 50%. Somatic mutations can be around 30% or less. In the setting of revertant mosaicism, in contrast, if we look at fibroblasts and sperm, we still expect a variant allele frequency of about 50%, but the VAF in peripheral blood and bone marrow can be considerably lower. And then in gonadal mosaicism, peripheral blood, bone marrow, and fibroblasts will be negative for the mutation. However, sperm will be positive. And in this setting, the offspring will have 50% or germline mutation in all of those tissues sequenced. And this is what we see in patients with de novo germline mutations. So what are the mechanisms for somatic genetic rescue? If we look at this example of autosomal dominant mutations, there can be single nucleotide substitutions that result in a different variant that abrogates the phenotype, or it can be completely revertant to wild type. There's also copy-neutral loss of heterozygosity. This often happens in the setting of uniparental disomy, or there can be a second variant that occurs that abrogates the original mutation, or mutation in a modifying gene that modifies the original mutation. The mechanisms are similar in patients with autosomal recessive mutations or compound heterozygous mutations or X-linked mutations. However, the copy-neutral LOH actually requires the presence of a wild-type allele. So talking about somatic genetic rescue, SAMD9L is a poster child for this process. There's a high degree of bone marrow plasticity in patients with this disease. SAMD9L mutations are gain-of-function mutations that are toxic to cells. There are multiple cellular mechanisms for abrogating and reverting this phenotype. One common mechanism is through the uniparental disomy. SAMD9L is on chromosome 7, so if there's UDP of chromosome 7, there's loss of the mutation resulting in 2 wild-type copies and recovery. Another mechanism is the acquisition of a loss-of-function mutation in cis that results in recovery. And then another maladaptive mechanism is actually the development of monosomy 7, where the cell is actually loses the copy of the 7th chromosome harboring the mutation. The problem with this type of adaptation is that it can result in MDS or acute myeloid leukemia. In any of these settings, though, the variant allele frequency of the SAMD9L mutation will be very low, and this is why it actually took so long to discover this disease. The importance of clinically detecting germline pathogenic mutations. Obviously, it's important for proper surveillance of disease progression. It informs therapies, allows for genetic counseling and screening of donors for transplant. As we've talked about multiple times, and yesterday in particular, the penetrance and expressivity may be highly variable within family members harboring the same germline mutation. Obviously, there can be asymptomatic family members and family members with debilitating disease. This is particularly important to recognize in a transplant setting, and here's an example clinical case. This was from a 21-year-old male who presented with pancytopenia. He had no history of infection or warts, no known family history of MDS. And this was his bone marrow biopsy, we can see that the marrow is very hypocellular, and there are a number of very immature-looking cells that are positive for CD34, consistent with blasts. And here's the aspirate smear you can see with sheets of blasts. Flow cytometry identified that the blasts were myeloid in origin. Cytogenetics showed monosomy 7. A very limited NGS panel was done that identified an NRAS mutation. The patient underwent haploidentical stem cell transplant using his healthy mother as the donor. A year later, the patient became cytopenic, and we could see that the bone marrow was hypocellular for age with very dysplastic megakaryocytes and dyserythropoiesis, consistent with MDS. However, what was really shocking was that the karyotype came back 45XX minus 7. So this was monosomy 7 in the mother's donor cells, and there was 100% chimerism. The patient and mother came to NIH and were sequenced and were found to be positive for germline GATA2 mutation. So this is a case of donor-derived MDS in the setting of germline GATA2 mutation. We published a number of families that had similar situations and showed that the use of a mutation-positive donor, no matter how healthy the asymptomatic carrier is, can result in donor-derived MDS or AML, poor engraftment, or failure of immune reconstitution leading to fatal infections. This has been described for a number of families having germline mutations predisposing to malignancy. So we recommended that all pediatric and young adults diagnosed with MDS or AML who will be transplanted using a related donor should be tested for germline mutations. So
2 minutes, please.
In summary, the germline mutations leading to immunodeficiency and hematologic malignancies are more common than previously thought and may be detected on targeted panels designed for somatic mutations if the gene is on the panel. There's an overlap in the variant allele frequencies and mutation sites between germline and somatic variants. Cultured skin fibroblasts are the gold standard for germline testing. Somatic mutations can be drivers of benign disease, and great examples are RALD, VEXAS, and PNH. And somatic rescue in hematopoietic cells is common in some genetic diseases and can complicate the detection of the germline variant. So, thank you.
Thank you very much. Our next speaker is Matthew Robinson from Johns Hopkins, who will be talking about incorporating pathogen genomic data into the electronic health record.
Thank you for giving me the opportunity to present today. I'm an infectious diseases clinician at Hopkins. So we've been, of course, talking about host genomic data. I'm going to be talking about pathogen genomic data, which is, I know, a bit of a departure. I'll talk briefly about a brief history of its use in clinical care and try to conceptualize a broad ecosystem of pathogen genomics. Talk about how we use whole genome sequencing for detection of drug resistance and transmission, some stuff about metagenomic sequencing, and the limitations of using these technologies in infectious disease diagnostics and some emerging technologies. So this is obviously not new. We've been using nucleic acid tests to identify viruses since the late 80s. Not myself, I was in kindergarten or something. But the first FDA-approved test to use PCR was in 1993 for chlamydia. By 96, we had an FDA-approved HIV viral load assay. And by 1999, we had evidence that testing for HIV resistance or genotype could improve HIV care. So to think about this topic broadly, I think we can think about it by the technical modality or the clinical application. So let's dive into these in some detail. So if we think about nucleic acid amplification tests, I'm sure everyone here has had a SARS-CoV-2 PCR at some point done on them. Outside of respiratory viruses, we frequently use gnats for difficult to culture bacteria such as chlamydia, for CSF analysis, for HSV, for viral quantification of HIV, hepatitis C, EBV. And we also use it frequently for identifying antimicrobial resistance genes. For example, MECA-C for MRSA and nasal swabs or blood cultures, CTXM for extended spectrum beta-lactamase producing Enterobacterales, and then in HIV, obviously, we used the genotype to look for resistance. Now, for some nucleic acid tests, reporting into the electronic health record is very straightforward. Like when we're detecting a pathogen, it's there or it's not. Quantifying it is also relatively straightforward. An HIV viral load does not look so different in the electronic health record as a, for example, creatinine test. However, AMR gene detection is a little bit more challenging. So some AMR genes definitely confirm resistance, but not always. And when an AMR gene is not detected, it does not guarantee susceptibility to the antibiotic of interest. Oftentimes, these results are buried in comments and not presented in a standard way, which is really a challenge for scaling observational health research. We want to learn how these can be most useful. Whole genome sequencing is increasingly used in clinical practice. When the lab identifies bacteria or fungi that grow in culture but are unidentified by conventional methods, whole genome sequencing is frequently used for its diagnosis. I'll talk briefly about how we can use it to identify resistance genes. For HIV, this has been done, like I mentioned, for 25 years, but for tuberculosis, this is more recent. We also use it for strain identification and relatedness. For SARS-CoV-2, we use it to predict illness severity, distinguish new infections from relapse, particularly in immunocompromised individuals. And then in the setting of determining whether or not transmission is occurring in healthcare settings, it's been quite useful. So for tuberculosis, about 15% of tuberculosis cases are resistant to first-line rifampin or isoniazid. Now, the turnaround time for conventional TB drug susceptibility testing is 6 to 8 weeks. Although there are existing nucleic acid amplification tests for isoniazid and rifampin resistance, there are a lot of other drugs that are used for TB treatment. So whole genome sequencing can be rapidly performed once you have a positive culture. And so there's been a massive effort worldwide to try to correlate the TB genotype with the drug susceptibility testing profile. And this report here for the WHO includes about 40,000 isolates. This works well for some drugs, but for others, we really need more data to correlate the genotype to phenotype. The interpretations of some of these results is challenging and not always so straightforward. But this is already entering clinical practice. So there is a panel offered for Illumina instruments, the GenoScreen Dplex, and then for Oxford Nanopore instruments, they also have a test out there. Now, this is actually using direct from specimen amplicon sequencing. So the idea is there's 24 amplicons that are sequenced to look for known variants which convey resistance. And this works well for some of the more traditional drugs like rifampin and isoniazid and fluoroquinolones. They get about 80% sensitivity for injectables. The problem is there are a lot of newer agents for tuberculosis entering care, and the correlation of the genotype and phenotype is not quite there yet for some of them. I'll briefly talk about my colleague Jeff Tornheim's work, who is trying to perform whole genome sequencing directly from clinical specimens rather than the amplicon sequencing, so that there's more data to evaluate for resistance to these newer agents, for example, delaminid and bedaquiline and linezolid, which have traditionally not been very easily detectable by these other technologies. Now, currently it's not quite there, but it's a work in progress, and I think there's hope that we can use this information to more rapidly guide therapy for this disease, which is oftentimes very difficult to treat. Now, I'm going to shift gears a little bit and talk about whole genome sequencing for infection prevention and control. So this work done by NHGRI scientists was particularly fascinating when it was first performed. So in 2011, there were 18 cases of carbapenem-resistant Klebsiella pneumoniae in the clinical center. At that time, this was a very unusual pattern to identify. So they performed whole genome sequencing, combined it with epidemiologic data to really identify in great detail the likely route of transmission through the clinical center. Now, we've been working on applying this same principle in other settings, and at Hopkins now, the infection prevention and control team can now order whole genome sequencing for bacteria to help them resolve these challenging transmission investigation cases. I work in India. We're also doing this in intensive care units where carbapenem-resistant organisms are a major challenge. This year is just showing 19 cases of Klebsiella pneumoniae observed in a neonatal intensive care unit. And you can see here that there is overlap in the hospitalizations among patients with very closely related isolates. In fact, a little more than half of all gram-negative bloodstream infections that we observed in this neonatal intensive care unit were closely related to another bacteria also observed in that unit. Now, we're trying to expand this capacity, and so here we have in a public hospital in India, they have a MySeq instrument, and now the wet and dry lab capacity to perform whole genome sequencing on bacterial samples to look for emerging mechanisms of resistance and to resolve issues of strain relatedness. So I'll shift gears now and talk about metagenomic next-generation sequencing and its potential for use in infectious diseases diagnostics. So 10 years ago, there was a really kind of shocking diagnosis of a 14-year-old boy with a severe combined immunodeficiency who had had fever and headache for 4 months with no diagnosis, progressed to the point where he was in the ICU in a pentobarbital-induced coma for seizures, and no diagnosis established. And they did metagenomic next-generation sequencing of the CSF, which identified a Leptospira species. The diagnosis informed the boy's treatment, and he recovered. Soon after this, we were interested at Hopkins, could we also apply this to diagnostic challenges? So this is a patient here that I saw while I was in my fellowship of a patient with encephalitis that underwent brain biopsy showing granulomatous inflammation, but still no diagnosis. And so they performed next-generation sequencing and identified 15 reads of Mycobacterium tuberculosis, started anti-tuberculosis treatment, and the patient recovered, and you can see their brain MRI improved on that therapy. Now, this was an excellent case, and the other one I showed were exciting, but the question is, can this actually be implemented at scale? And so at UCSF, they published their experience recently, which showed the performance of metagenomic next-generation sequencing for nearly 5,000 cases for CSF, and about 14% of them were positive for at least one organism, mostly viruses, but really across all domains. So I pulled a few of the more interesting diagnoses from this paper. They had some cases of tuberculosis identified, Lyme disease, and some arboviruses such as powassan, and others that are obscure enough that it's difficult to find a test for them normally, and also some parasites that are very difficult to treat. And in 30% of these cases, metagenomic sequencing was either the first or the only diagnostic modality to make the diagnosis. At Hopkins, we are also doing metagenomic next-generation sequencing for meningoencephalitis. So the protocol is slightly different, but we really prioritize using negative controls to minimize the false positives. And this work is led by Trish Simner and Carlos Pardo. It's a multi-day process. It's still not easy, and there is still a bioinformatics component that needs to be done to analyze the results. Overall, we can make exciting diagnoses, but it's important to note the limit of detection generally is is not as good as a dedicated nucleic acid amplification test. So for example here, you'll see that for RNA viruses, the limit of the detection in this work showed that it was around 100 genomes per ml, which is going to be higher than it would be for a directed PCR test. And so like when I speak to medical students, I ask them, what is the most sensitive modality of diagnostics? And oftentimes they reach for sequencing, but really if you know what you think the diagnosis is, it's not going to be the most analytically sensitive test, but can really help when the diagnosis is unknown. Just shifting to blood, so clinicians are now starting to use microbial cell-free DNA sequencing for pathogen detection. There's a company, Carius, that offers this test. They include more than 1,500 organisms. An early report of its practices showed that they found something in more than half of specimens. They report their results as molecules per microliter or molecules per 100 nanoliters, depending on when it was done. And a positive test by this technology is now considered to meet major criteria for endocarditis, for Coxiella, Bartonella, and T. whipple. So it is entering clinical practice. But there are some challenges. These results are not so easy to interpret. So this is part of the informatics pipeline for the case I showed previously. So it is done in a run with some other patients. And you see this one at the top here.
1 minute, please.
So anyways, it was able to, if you look at just the read counts, you're going to overcall something and miss others. If you normalize by % reads per specimen, it can be more specific. We also were able to identify Rickettsia conneri for the first time in sub-Saharan Africa with some sequencing. And so the main limitations are its cost and the interpretability. I'll briefly mention FIPSeq, which is an antibody test that uses sequencing to resolve the results, and it was used to diagnose dengue panencephalitis. And then we adopted it for arboviruses as well. So in summary, it's already, pathogen genomic data is informing patient care, but the interpretation, reporting, and high costs really do remain a challenge.
Thank you very much. And we'll move on to our final speaker of the session, Dr. Bob Nussbaum from UCSF. What motivates clinicians to use molecular diagnostics, and what obstacles are encountered that deter them? Personal view.
So these are my disclosures. Invitae was a company that I joined in 2015 because it held a promise of trying to democratize and integrate genetic testing into mainstream medicine. This is a talk that's from the point of view of a large centralized laboratory running hundreds of thousands of tests using next-generation sequencing, primarily panels, but also exomes. And as a commercial laboratory that was dependent on reimbursement for keeping its lights on. So everybody knows Ohm's law. The amps and current in amps is equal to the ratio of the voltage or volts to the resistance, R. That's Ohm's law. This is Ohm's law, where A is adoption, V is motivation, and R is resistance. So I'd like to talk about motivation and resistance. Motivation, number one. We've all heard, and it is undeniable, that a test has to be considered standard of care to really drive its usage. This is generally determined by professional organizations like NCCN, USPSTF, MolDX, which is part of the Medicare, Palmetto Medicare contractor, and the various specialty colleges, cardiology, breast surgeons, et cetera. Another way that motivates physicians to use this testing is it's required for the practitioners to meet performance metrics, and that's determined by individual healthcare organizations. And these decisions are generally based on that the test has proven clinical validity, has evidence of clinical utility, and in some cases, it can actually demonstrate economic benefit. And this, of course, is the most compelling piece of evidence. The other part of motivation is the doctors and the patients. Are the physicians aware that the test is available and what it's good for, and how comfortable are they in using it? And this differs tremendously by specialty, the natures of the practitioner's CME activity, and how much hand-holding they've had by genetic counselors, or in the case of pharmacogenetics, how much hand-holding they have from the pharmacists in their institution. And also commercial laboratory advertising and patient demands. The patients saying, going to their doctors and saying, I think I need this test or that test that I read about, and you all know the Angelina Jolie phenomenon with the breast cancer, hereditary breast cancer testing, and the contrast between that and Katie Couric's efforts to get an equal interest in hereditary colon cancer testing, which was far less successful. Now, let's talk about resistance. Number one is gatekeeping. There are restrictive medical coverage policies. They deny coverage for many genetic tests, refer to them as experimental and investigational, when specific professional guidelines based on evidence of utility is lacking. And in some cases, the in-house tech assessment is really not up to par. In other cases, it's excellent. And so, you've dealt with one insurance company, you've dealt with one insurance company. It's very hard to draw conclusions across the entire industry. There's also, I would have to say, an adversarial relationship and a lack of trust between health insurance and diagnostic laboratories. They see the laboratories as having a fundamental conflict of interest. They want to sell more tests. And their basic interest is spend less money. And so do we have a way to come to some kind of balance that optimizes patient care? The definition of clinical utility varies a lot. As we heard this morning, the lack of evidence of clinical utility doesn't mean that there is no clinical utility. It can mean that there's just very difficult to obtain the evidence for clinical utility. And we heard from Morgan about how just having the patients be able to have an answer is, from a geneticist's point of view, is clinical utility. There are many other physicians and certainly many other health insurance that just giving an answer that doesn't change management, doesn't change therapy, is just not adequate for demonstrating clinical utility. Making a diagnosis and ending the diagnostic odyssey has certainly entered the realm of clinical utility because it's based on dollars and cents. You save one day in an ICU, and you have saved a lot of money. Improving prognostic precision is part of utility. And then finally, allowing genetic counseling and reproductive decision-making. Those are all aspects that I would consider to have clinical utility, but that is not generally accepted. Next is other resistance, which is what I call the sand in the gears. Health insurance coverage policies and requirements are not uniform among insurers. So you're faced with a laboratory that's dealing with, at one point I think we had over 300 million lives covered in the insurance companies that we dealt with. And the policies and the requirements differed. So every patient who came in, may be quite different from the previous one that you saw in terms of, well, do you get reimbursed for this? What is the coverage? How much is the coverage? And there's some very burdensome requirements for documentation. They drive up administrative costs quite a bit. Pre-authorizations for covered tests. And even if no pre-auth is required, letters of medical necessity are required. Now, I feel for the insurance companies. They are inundated. There are tens of thousands of laboratory-developed tests out there. And they're getting dozens across their desk every week. And they have to figure out, is that a good use of our clients' money? And the clients generally being the employers who are paying the health insurance for employees. I have to say that there's also a role for the third-party administrators. There are many healthcare companies that say, look, we're just going to subcontract this out to a group similar to the pharmacy benefits management, but they are going to be managing whether or not any genetic testing is going to be covered. There's also, I think, some element of just say no and hope they go away. There's this ProPublica report, how Cigna saved millions by having its doctors reject claims without reading them. and there's the URL, and this has been repeated in other areas as well. And I hesitate to put this up, of course, because of the tragedy of the murder of Mr. Thompson, which is, I think, a reflection, not so much his murder is a reflection of one individual's decision to do something, but the social media reaction to that murder, I think, is appalling, but also reflects a tremendous amount of dissatisfaction and frustration with dealing with our current healthcare insurance system. Our experience, by the way, we did a study, and Ed Esplin has been running this, where we looked at a whole bunch of claims denials. We're talking about tens of thousands and thousands of claims denials, and went back and appealed them, and more than half we ended up getting reimbursement for it. And when you look back on why the original one was denied, some of it was just health coverage policy, just the sort of the gatekeeper thing. But a lot of it was they just didn't feel like they got adequate documentation, so that you have to pull together the documentation and get it appealed. Well, that is an enormous cost. I mean, I don't think people recognize, I mentioned it yesterday, that our billing group was larger than our entire genomics variant interpretation group. And if you ask a question, what does it take for a commercial laboratory to survive? I don't want to give any specific numbers because I don't think they are sort of out of the proprietary range. But just imagine, gross margin really needs to be over 70%, which means that nearly 70% of your entire revenue needs to be something that's cost of goods and services, and the rest is all administrative burden, sales force, et cetera, et cetera. The other resistance is the awkward and time-consuming workflows for practitioners. I mean, physicians are under tremendous stress. The introduction of the electronic health record has in some cases been helpful, but in many cases has actually extended work days. I know when I was seeing patients regularly, I would do my electronic medical record work in the evening after a full day in clinic. Well, I didn't have to do that before. I just wrote the note while I was in clinic. Having to go outside of the EMR, to go to a separate portal, which is what Invitae had to do because we were not integrated into the electronic health records and are still not integrated in many places. I think that's a non-starter for physicians to have to get out of their system, not to mention the fact that many healthcare organizations are very loath to allow their institutional computers to address and go to outside groups without very stringent security checks, which in many cases required months, 6 months to 9 months for an institution. And that's just one institution. So you have to do it institution by institution to allow your portal to be utilized. And the negative impact on practice workflows for physicians who are unaccustomed to ordering genetic testing. The need for pre-test counseling for whole exome or whole genome, the fact that, as Morgan pointed out, you find incidental findings. You also have to ask them, do you want secondary findings or not? There is a burden. It's not just like ordering a CBC. Practitioners have to consider factors they don't face. I mean, urologists are told, advanced prostate cancer, metastatic cancer, you should be looking at homologous recombination genes like BRCA1 and 2. Well, bingo, now you've got other people in the family, both males and particularly females, that you are now potentially responsible for encouraging them to have cascade testing because of the high risk of breast and ovarian cancer if you find a positive in BRCA1 or 2. And I also have to say referrals to genetics for support, which is sort of a standard way that many non-genetics practitioners get around this problem, is also problematic because of long wait times. I mean, I've heard stories of 3 to 6 months to get in to see a genetic counselor. That's a non-starter. This is not going to work for a busy breast surgeon to refer. With breast surgeons, what they want is to be able to get a test and have it test back within 5 to 7 days to know whether they should be considering bilateral mastectomy or not. And then finally, the FDA. In vitro diagnostics are regulated by the FDA. Laboratory-developed tests are these tests that are designed, manufactured, and used within a single laboratory, but they've become widespread. I mean, all of Invitae's tests were laboratory-developed tests. The FDA thinks there are more than 80,000 LDTs in circulation in the U.S. market now. It's an enormous number, and is the oversight over them proper and appropriate? We actually got FDA approval for one of our cancer panels at Invitae. It took over 2 years to happen, and by the time it happened, we'd already modified the panel to reflect ClinGen recommendations for gene phenotype correlations, as well as having improved the pipeline substantially. So I do think there's a problem with the FDA jumping in. I think it's going to decrease the number of tests entering the market. It's going to increase the cost of developing tests, and it will stifle innovation. But I think it'll also require improved evidence for clinical validity and utility, and it will improve reimbursement for approved tests. I think that having an FDA approval, seal of approval, is helpful. So, educate medical and payer communities on accepting a broader definition of clinical utility. I think that's important. We have to organize specialty physicians to push for guidelines and recommendations within their societies. The difference between what NCCN thinks a breast cancer patient should receive in terms of testing and what the American Society of Breast Surgeons is quite different. There are 5 different guidelines for prostate cancer testing, depending on whether it's the European group, it's the American prostate group, the American urological. These guidelines need to be unified and pushed by the professional societies. We have to develop software solutions for pre-auths and letters of medical necessity while we work towards getting approvals. I think the testing should just be linked to ICD codes. Julian, I'm sure, has got lots of comments and probably criticisms on that. But the idea being, for a given diagnosis, a given genetic test is indicated. And having to provide additional stuff that maybe they don't even look at until you appeal the result is just a very burdensome problem. We have to integrate ordering and results reporting in the EHR. Sort of popping out through these outside portals is just sand in the gears. We have to develop better patient education tools. We've heard about some at this meeting that streamline pre-test counseling, reduce the burden on providers. We have to empower non-genetics providers to order testing and use it. If it all depends on whether medical geneticists, genetic counselors are providing it, it's never going to go anywhere because there's too few of them. Clinical decision support that identifies which patients need it, and we have to work with the FDA, which we did, and I think they listened to a lot of what we had to say about how their standard model for FDA approval of an analyte test just did not apply when you're looking at 47 genes, and you had to detect a bunch of variants, some of which you didn't even know exist until you actually do the test. And with that, I'll stop. Thank you.
Great, thank you very much. We'll move to questions, and we have until 12:30. Terry, am I right on that? Till 12:30 we have for discussion right now.
That's correct.
So right now it's 11:52, which gives us about 38 minutes. And I see at the very end of the table, I can't see the person, but I can see a stand-up card. Oh, Steve Holland.
Hi, just a question for Bob. Bob, that was really rousing, and I'm ready to lobby right now. So you talked about tying testing to ICD codes, and that makes a lot of good sense. On the other hand, as we've been talking about in terms of pharmacogenomics and the broader implication of secondary findings, if we tie individual tests to individual codes, won't we wind up still arguing about when we should do, either big panels or whole genome? And how would you address that?
I think the idea of having specific panels tied to particular diagnoses is really designed for trying to solve what I think is a current problem, which is the overwhelming administrative burden of pre-auths and letters of medical necessity. Ultimately, I would expect that we will be having genome testing done on people before you even know that they have a particular diagnosis, because we're going to use that information for prevention in the PGX world, or for prevention in the carrier detection world, or to inform when someone does develop symptoms and signs. You can say, you know what, we can understand this and interpret it based on the genome. So I think it's a transition. I don't think it's an end result.
I would add on to that, and in part because I was provoked to talk about my opinions on ICD coding and policy. I'm actually a huge fan, and it's really for more of a logistical reason, which I think speaks to your question as well, which is that there are two ways to enforce policy through payers. You can do it manually by reviewing records and having a physician determine whether they hold the opinion that is medically necessary, or you can implement coverage rules that are based on CPTs and ICDs and allow it to run in an automated way. And I think that that is a key part of the strategy towards reducing prior auth, is to make those sort of rules. So even though the rules may be less granular, less specific, and sort of lack the art of medicine, they are much faster and easier to implement at that level, and can ease some of the administrative burden. And so I think it's useful from that perspective.
Julie, there's a question.
Oh,
behind.
oh, great. Yes, next question.
Hi, Maggie Morris-Fears from NIAID Date. I think, too, a part of the administrative burden falls on the patients and their families. I mean, I am in close contact with a lot of patients with type 1 diabetes. It's on. Am I not close enough? Okay. So I have a lot of contact with patients and families that deal with type 1 diabetes, and the number of hours that they spend on hold trying to get all the authorizations for a chronic condition. They're like, oh, it's a new year, you don't need test strips now, you're cured. I mean, it's a huge burden, not only on the medical providers, but also all of the patients too. And I often think about the patients that don't know how to navigate the system, or just don't have time to navigate the system, and how can we make it easier for them too in this whole process. And certainly that applies to chronic diseases across the board, and all of these testing results that we're talking about here.
I think that's an important observation. Terry, I think I saw your card go up next.
It is up, but Mark raised his hand while Maggie was speaking. Mark, do you want to speak to
No
Maggie's
response
point,
to that.
or is it something different?
This was to the prior point of the discussion about coding. First of all, I'll just make an editorial comment that the danger of having a presentation like Bob's in a setting where we have multiple talks is that we will spend all of our discussion time on this topic, because it is the most painful topic that we all deal with. So just as a comment to the moderator, I'll make that. And then, of course, not being able to resist adding on, despite what I just said, I would note that ICD and CPT codes, while I agree are extremely useful, are also not under the control of the entities that actually use them. So CPT is controlled by AMA. There's limited ways to be able to impact the availability of those codes. ICD is an international classification. The rest of the world is about 2 ICD modifications beyond where the United States is. We're on 10. I think the rest of the world is at least on 11, if not 12. And again, there's limited ability to make sure that those ICD codes are actually granular enough and context specific enough to support the intention, which is not to support billing, but to support epidemiological studies. So, even though these look to be relatively reasonable suggestions in terms of how to make things more logical, we're again using things that were not for a purpose for which they were not specifically designed. That's ICD. CPT obviously was specifically designed for reimbursement. And the last thing I'll say is I have a talk that's my favorite that's called The United States Healthcare System Evolution versus Intelligent Design. I think that you all know where I land on that one. So
I should just mention also, particularly ICD-10 codes are terrible for rare diseases. And so it really puts people with rare diseases at a disadvantage.
So I'm going to try to rescue us from this morass, at least for a little while, and ask Matthew, could you speak, and maybe David, you could comment on this as well. How do we get the pathogen genomic information into the medical record in a way that it travels with the patient? So when we have patients who have extended spectrum beta-lactamase organisms, that sometimes is buried in some culture result somewhere, or sometimes it gets pulled out. And David, I think in the past, the HIV genome, there would be some notation if there was a particular drug to be used for it, but I could be wrong. So I wonder if you could comment on that specifically in terms of the informatic aspects of getting some other genome into a patient's record.
That's a great question, and it's a challenge, I think, also because there's also not always an incentive to do it in that way. Many of these tests are stood up by individual laboratories, and there's separate laboratory information management systems that integrate with the EHR differently across different institutions. There's work to create common data models such as OMOP, which serve as a sort of a layer on top of standard terminologies that links them hierarchically and also with ontologies. So I think, at the most basic level, when you record a result in an electronic health record, it's important to make sure that it gets entered as structured data at that initial point. After that, there are some additional steps I think that we can take to harmonize between different structured formats. But currently, like you said, so much is just free text buried into comments that will never get easily integrated.
And I'll comment, even with HIV, which folks have worked on for a long time, the resistance testing on the virus itself, which is extensive sequencing, the way the data comes back, it comes back in different formats from different sources, different laboratories. So we, at Vanderbilt, we end up looking at PDFs of lots and lots of different things, which are very interpretable, but it's very problematic for obvious reasons, part of which is because the genetics change over time. Someone who looks very sensitive now could have been highly resistant 10 years ago, and they are still resistant. You just don't see it in what's in their blood. So it is, in an area that should be very straightforward, it is a morass. Yeah.
Another question down to my right.
Hi, I'm going to go back to the painful topic. So if the most efficient way to enforce the implementation of genetic testing is through ICD-10 plus coding, how can we help? What is our process? How do we mandate that? What is the governing body? I don't know, so I would like to know a little bit more if somebody knows.
So, I can only speak to this because we've had some conversations recently, and there have been, basically, it is very hard to get a new ICD-10 code in between version updates. And what the specific details are a little bit unclear, but the situations in which this has occurred have been actually all industry-led, at least within the immunology world, where there's a company that had like a PI3 kinase inhibitor and needed there to be an ICD-10 code for PI3 kinase gain-of-function disease so that they could have appropriate billing for that drug. And that took sort of a team of lawyers within that company. We were seeking to get one for malignancy-associated HLH, and that was kind of a non-starter just in terms of the barriers. So there are people with experience doing that, but doing that at scale would probably require revisiting the whole process, which is not a bad idea, but is maybe something that could come out of this.
Well, but so I still don't understand. Who do I email so we start this? Like the lawyers, is it a law office or is it a advising body? Who is do we know?
It's not one place, I don't think.
It's not one place, okay. Okay.
And besides, why should we tell you when all the rest of us have had to struggle with navigating it? That's half the fun.
Stephen Kingsmore and then David Haas, unless you were going to respond to that. No, okay.
Yeah, it seems to me like it's all doom and gloom here, and it's not actually, okay? Remember that the focus here is on severe, well, a lot of the focus is on severe acute infectious disease and figuring out solutions to inform genomic medicine. So most of these kids, you know, there's a time essence here. All of the Medicaid policies and the private payer policies to date for rapid diagnostic genome sequencing have not required prior authorization because there isn't time. There just isn't time. A physician needs to be able to order a test immediately and get results, ideally in a day or two, so in time to save a child's life. Those coverage policies are really well written. They are on track with the clinical needs. As I mentioned, right now there is no mention whatsoever of infectious disease, so that's a glaring omission, but it's remediable. We just need evidence. And the payment schedule is also equitable. They pretty much are covering the costs under the CPT codes that are associated with rapid diagnostic genome and exome sequencing. So I know that in general this area is a mess, but that's outpatient testing, non-emergent outpatient testing. We're seeing a very different set of policies and an enlightened audience in terms of Medicaid medical directors and medical directors at some payors based on building up this really sound evidence base. So, you know, I don't want us to get into some kind of tailspin here to say, oh, this is hopeless. It's not hopeless, it's quite tractable actually for this specific application. Now, it would be lovely to get that extended to places like emergency departments, so not just the NICU and the PICU and the CVICU. It would be lovely to get it extended to patients who are on the floors and aren't quite sick enough to make it to the ICU. So I think, you know, we go with what we got, and then we want to prove out that these strategies are actually working, and then look for targeted expansions. Sorry.
Can I just ask, related to that, though, how much of that do you think is because you're dealing with sick kids and they have maybe a more sympathetic ear for sick kids than they would for some, you know, adult who's had a chronic condition?
So it's definitely related to the context, right? So in an intensive care unit, every insurer realizes that these are in essence, by definition, outlier patients under their plan, and they're going to incur considerable cost. What has been incredibly effective is to show reduced length of stay and to help them understand that an enlightened policy results in a net lower cost for them at the end of the day.
But that is sort of a special situation. I mean, compared to a lot of the other ones that we've been talking about throughout this meeting.
Not from my perspective, because that's my life.
Yeah, so I'm wondering, you know, a lot of this is because we don't have a universal healthcare system where we don't have all these barriers. But I wonder if there are lessons learned from places where there is universal healthcare. The closest thing in the U.S. maybe being the VA system. I don't work in the VA system, so I don't know. But for example, with the Million Veterans Project, are those being used at all clinically, or is that purely research? And are there places that have implemented universal, you know, extensive sequencing and been able to show benefit from that? I should know this, but I don't.
So the VA is using it for pharmacogenetics. I'm not aware of them using, you know, broad sequencing, maybe Gail or someone else knows, for diagnosis or risk prediction or whatever. St. Jude Children's Hospital, Children's Research Institute does a lot of pharmacogenetic testing again, and I believe they do more in the way of sequencing, but maybe others. Mark, obviously Geisinger has a whole system set up for doing this. You want to comment, Mark?
Yeah, so the largest part of the project is in a research setting where we do screening and then do clinical confirmation to return results, and we've returned over 5,000 results. We've tried to implement in a pilot study actual clinical grade exome sequencing, and we have about approaching 2,000 individuals that have been sequenced where we can directly return results, which mostly matches the ACMG list to participants. But to be honest, that's required a certain amount of subsidization and is being covered by the health plan under sort of a special, one might call it a coverage with evidence generation. So I wouldn't say we have a fully implemented program.
Great. Inga, I think you have the next question.
Yeah, less a question, more a comment. I'm not sure if you're familiar with the NCAT, that's the National Center for Advancing Biomedical Translation. They had, during COVID, they had a pilot project that was called the N3C, which was, I think, around 70 to 75 institutions bringing together, submitting or sharing electronic health records with, I think they had a data broker in between to find out risk factors and others for SARS-CoV-2. And I know there was a pilot that also included to incorporate pathogen, so SARS-CoV-2 genomic data into that. I don't know how far it went and if it's in there. I know there were discussions around data sharing of the pathogen genomic sequences and how to make those publicly available while still keeping them out of the privacy areas of the electronic health records. But I just found out they also now expanded it to other health conditions. I'm not sure if patient genomic sequencing is part of that, but it would be worth looking into it. 75 institutions across the United States are participating, as far as I know.
Thank you. Do you have a follow-up to that, or?
Well, I just speak briefly about N3C. It's a very exciting collaboration. I think the challenge is that that's really for observational research and not for clinical care. It uses the OMOP common data model. It uses a Palantir data broker, and it is being expanded for things beyond COVID. And I think it's very exciting for future observational health research. But it itself, I don't think, is intended for any clinical applications.
I was just going to say, for genomics, the holdup isn't the sharing. I mean, the Office of the National Coordinator and the requirement that patients be able to get their data as a requirement is all right. The problem is that the information is not in the healthcare system in a way that's accessible. I mean, I just heard this morning one of the premier universities for genomics and genetics in the United States doesn't have the EPIC genome module installed at their institution because their institution apparently hasn't decided that it's high enough priority to pay for it. So I think we have to get that straightened out, and then people can pull the data from everywhere. They have to be able to pull it by federal mandate, right? The Cures Act?
Additional comments?
I can comment briefly on that, just to mention that the ACMG has published a couple of points to consider articles on availability of data, including what would constitute a designated record set for a request that would come to a laboratory for requesting genomic data, and also some broader considerations regarding, what responsibilities are when such a request comes in, and what type of considerations should be given to education, counseling of patients. But in neither of those documents, nor to my knowledge, is there any sort of overarching solutions, such as what Bob is advocating for in terms of a more standardized way to move the data around, because as much as Terry referenced the need to move pathogen-specific information, we all know and have talked in multiple venues about the need that germline sequence information has to move with the patient. It has to be patient-centered. You can't have an institutional center as we do with most healthcare data.
Matthew, I think you had something to say next.
So there are, existing software solutions to this. I mean, HL7 messaging exists to, transfer information between institutions. Oftentimes, the problem is more just how to use and interpret it. I mean, I will say that with large language models, I think it's going to become much easier to take unstructured data and make it structured. But there's still a lot of communication, a lot of work that has to be done to make this usable.
Yeah, again, if I can re-weigh in there, the HL7 Genomics Working Group has been working on this for a lot of years. They have some proposed solutions, but to assume that genomic data can be transferred robustly and accurately through HL7 is a pipe dream at this point. And I think there's also been some interesting work done in the Undiagnosed Diseases Network about use of large language models to take the volumes of information that are submitted with patients and transforming that into structured data. That looks very promising, but again, I think early days there, and there's a lot to be learned about that, particularly given the experience that has been seen both in the UDN and much more broadly about the tendency of large language models to hallucinate from time to time, which would have catastrophic effects in clinical care.
I was just looking to see if lunch is there, if you want to stop. But
Are there any more questions or comments where we can break a little bit early for lunch if they're not? And then we would come back early and we would start up again at 12:45 if we break now. Sound okay to everybody? Great. Thank you so much to all your speakers and to everyone who contributed to the discussion.
and the lunch is outside, that's what I was checking on.